Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Population-Wide Screening for Germline BRCA1 and BRCA2 Mutations, Too Much of a Good Thing, by Matthew Yergelin et al. My name is Jennifer Axelbund, and I am a genetic counselor and assistant professor of oncology at the Johns Hopkins University School of Medicine in Baltimore, Maryland, USA. My oncologic specialty is inherited cancer syndromes. The BRCA1 and BRCA2 genes have increasingly been the subject of public attention, owing in part to high-profile stories such as the United States Supreme Court decision regarding gene patenting and actress Angelina Jolie's revelation that she is a BRCA1 mutation carrier. Most recently, Dr. Mary Claire King, who is credited with discovering BRCA1, intensified interest by recommending screening for BRCA1 and BRCA2 mutations in all U.S. women at 30 years old. Dr. King and colleagues cited their 2014 PNAS publication as evidence of the importance, feasibility, and cost-effectiveness of population-wide screening. This Israeli-based study provided mutation screening to the Ashkenazim at large. The main impetus for Dr. King's appeal was that half of identified mutation carriers would not have qualified for genetic testing using family history-based criteria. However, they appear to face the same markedly elevated cancer risks. Thus, given the effectiveness of breast and ovarian cancer risk-reducing strategies, identification of unsuspecting mutation carriers could dramatically impact patient care and public health. In their commentary, Dr. Yergelin and co-authors commend Dr. King, but also point out a number of issues that limit the generalizability of Dr. King's data and subsequent proclamation. They suggest that population-wide screening of BRCA1 and BRCA2 is far from ready for implementation and raise such concerns as discrimination and cultural considerations, unknown penetrance for non-founder mutations identified in the absence of family history, and potential societal pressures associated with genetic testing at a prescribed age. They also question the uptake of risk-reducing strategies outside of intensive genetic counseling and point out the potential demand for genetic counseling that exceeds the current supply of trained genetic counselors. Perhaps most substantial is the issue of variants of uncertain significance, which are DNA alterations of unknown pathogenicity. In the Ashkenazim, uncertain variants are generally a non-issue due to founder mutation predominance. However, in the United States, where the majority of individuals are of diversified ancestry, comprehensive analysis of the BRCA1 and BRCA2 genes would be necessary. This would result in a significantly higher percentage of uncertain variants than of pathogenic mutations. Dr. King recommends that uncertain variants not be disclosed, but Dr. Yergelin's commentary articulates the considerable downsides to this approach. Of greatest concern is that some individuals will essentially receive false negative results, as a small but significant proportion of uncertain variants will eventually be reclassified as pathogenic. This will be even more pronounced in minorities, where lower testing rates have resulted in higher frequency of uncertain variants. Therefore, all people undergoing genetic testing would at least need post-test genetic counseling to inform them of the potentially conditional nature of their quote-unquote negative result. As such, an entire infrastructure must be created in order to deal with this specific issue, including a system for proactive recontact. Another consideration is that minorities, who have historically been more reluctant to adopt genetic medicine, may be at greater risk of being lost to follow-up regarding reclassification, which often occurs years after testing is pursued. Furthermore, assuming that tested individuals truly understand the concept of results reinterpretation, there are potential psychological ramifications of endlessly awaiting such recontact. One could argue then that uncertain variants should be disclosed. However, if the frequency of uncertain variants is 2 to 5%, depending upon ethnicity, the projected rate of uncertain variants would be as much as 20 times higher than that of pathogenic mutations, which have an estimated prevalence of 1 in 400. Therefore, at the population level, a considerable number of people could face the anxiety and screening dilemmas associated with uncertain results. As such, disclosure versus non-disclosure of uncertain variants is an issue that requires thoughtful and ongoing upfront dialogue. Another highly concerning issue that Dr. Yergelin and colleagues raise is failure to recognize the limitations of an indeterminate negative. This is the concept that testing of BRCA1 and BRCA2 is not an exhaustive assessment of cancer susceptibility, and lack of a BRCA1 or BRCA2 mutation does not equal elimination of breast or ovarian cancer risk. BRCA1 and BRCA2 are not a panacea for determination of cancer risk. Rather, they are only two genes associated with increased risk for specific malignancies. Other high and moderate penetrant cancer-associated genes have been identified, but high-risk individuals may fail to seek additional genetic evaluation if they are not fully informed of the limitations of testing only for BRCA1 and BRCA2. Rather, they may consider themselves to be no longer at risk for cancer, thereby even foregoing average risk screening. Preventing false reassurance is already emphasized during traditional pre- and post-test genetic counseling, but a new educational model would need to be developed if large-scale testing were performed. Otherwise, we run the risk of exacerbating the very problem we are striving to diminish. One promise of predictive genetic testing is reduction of morbidity and mortality from disease, and identification of BRCA1 and BRCA2 mutation carriers who would otherwise be unrecognized is an admirable goal. As Dr. Yergelin and colleagues write, Dr. King's appeal stimulated a much-needed discussion of this topic. However, Dr. King's recommendation is supported in large part by data that may not be generalizable to the people of the United States. Before any such program could be implemented, a system for focusing on education and follow-up, including outcomes data, must be developed and ideally piloted in a variety of communities. While preservation and enhancement of human life is a shared goal, it should always be compliant with first do no harm. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.